Have you been told you need to stop doing what you love, whether it's exercise, running, or a sport? Well, here at Dynamic, we don't like that answer. In this podcast, we'll talk to leaders in the health and wellness space from Southwest Florida to get the solutions you need to get you back to doing what you love. Welcome to the Dynamic Naples Podcast. What's going on, Southwest Florida? Today, I have a very special guest. I have Jeliena Krill on. She is a PA. Jeliena, how you doing today?
Good. How are you, Chris?
Good. Tell everybody where you work.
So I'm working in Southwest Florida, Fort Myers area at a surgical specialist at Southwest Florida. It's a general and vascular surgery practice.
Okay, very cool. Yeah, we'll dive into that in a bit. But a little background, I know Jeliena personally. She is married to one of my good friends, Mike, who I went to grad school with. And we all met in the gym back in the powerlifting days. Isn't that right? when I was trying to be a powerlifter.
We had fun.
Yes. So just give us a little background, like how did you get into healthcare? Like what made you interested in healthcare in the first place?
I mean, it's for me personally, it started young. I was, asking my mom, who was a nurse, what do you think I should do? And she knew I loved babysitting and children and things like that. And her first thing was be a pediatrician. So, I got that in my head from, young, probably like age 8, and kind of ran with it literally up through sophomore year of college. That's actually when I met my husband, Mike, your friend, my husband now. And he was like, why would you go to med school? He's always about finding the route, an easier route to get to what you want. He's like, well, what do you want to do? And I'm like, resistance. Yeah, I was like, I want to practice medicine and I want to help people. And, I want a job that's stable, and the medical field seems to be the place to go. So he was like, well, why wouldn't you just become a nurse practitioner or a PA? And I was like, I never even heard of it at that point. And I was like, well, let me look at the routes to go. And at the time, nursing route would have took a lot longer. Just because I would have had to get into the nursing program, and then you have to work a year before you can go to nurse practitioner school and things like that. And I didn't want what I've already put into college to go to waste. So then I learned more about PA and I started diving into that. So, and it worked out that my bio degree helped me get to that point. So.
Yeah, I would love to dive into what a PA is. I know what it is, but I think the average person thinks it's like literally an assistant. So describe what a PA is, what it stands for, and like what's the scope of practice.
So briefly, little past history, back in the 60s, there was a big physician shortage, and they were realizing that a lot of the medics and the, people in the Navy were doing a lot of, they're very skilled medically, and they found a route that would be great to get these, people into the field to help filling the gaps that for the lack of physicians there were. So they, the first class of PAs was in 1965 at Duke University. And it was kind of like the PA profession was put on like a fast track, like medical school to fill those gaps. So, and, and the profession has grown significantly on what we're capable of and, things like that since the 60s. Now we can prescribe, we can diagnose, treat, care plans. I mean, there's urgent cares that, the physicians and PAs and nurse practitioners are running, those places, and you don't have a doctor in sight, so yes, because of the word assistant being attached to our name, we get a lot of that. They kind of confuse our profession as like medical assistants, which they're amazing too. But, like our MAs in our office, they, do vitals, and some of them are able to do like different punctures depending on which practice you're in and things like that. But as a PA, we are a medical provider. We can, like I said, diagnose, treat, order labs, interpret them, prescribe and all those things. So
yeah, it's unfortunate, all the terminology, right? I mean, like I have a doctorate, but you can do way more than I can. Isn't that kind of funny?
But here's the thing, and we all know this as you've seen it too. Yeah. It's a degree push with every field. You start out with associates, then the bachelor's, master's, doctorates. There was a push at a period of time for PAs to become a doctorate. It's like, wait a second, the whole reason, this profession came to be is to, have a way to fill gaps. And if you make it long, then why wouldn't you become a physician, So,
Right.
yeah.
I kind of see it as like PAs are kind of doing the actual work, and like medical doctors, it depends on the setting, obviously, right? But a lot of medical doctors seem to be more like management of the PAs. Is that kind of what it's like?
So, as I've said, things kind of changed over all the years. And honestly, it even changes state by state. There's a lot of different pushes for more independence as PAs. In Florida, as the current situation is, we're under the supervision of. I know there's other terminology they're working on, of course, to try to make things more individualized. But like I said, what happens changes. As of when I was in school, and since, unless something changed, it was, you had to have a physician within 50 miles and a phone call away. Yeah. It's not like they have to be on site. They don't have to be seeing the patient you're seeing and things like that. It's kind of like you have that phone call if you feel that it's something you can't handle,
Gotcha. Yep. Mm-hmm. And so, I mean, PAs do surgery, and that's basically what you do most of your day, right?
So for surgery, like on my own, I do certain things. I remove tunnel catheters for dialysis. I can do incision and drainage. I can close wounds that open that, in certain situations. Otherwise, I am the first assist in the surgeries with the surgeons. With that being said, we get to we're very involved with the surgeries, and, we do a lot of the deep and superficial closures. We're involved throughout the whole process. So for big surgeries, no, we're not doing those independently. For smaller surgeries, yes, we could do those independently.
What are the type of patients you guys see mostly? Like, what are the main issues that you guys deal with at your center?
So in my particular office, I have 6 vascular surgeons and 1 general surgeon. All vascular surgeons have to be trained in general surgery prior to, continuing on for vascular surgery. So they're all capable of doing all things. So with that being said, general surgery, we're talking a lot of different things. You have your thyroid, your parathyroid surgeries, your appendix, gallbladder, hernia surgeries, colon surgeries, and then all like abscesses and all those little things like that. So when they say general surgery, it really is a lot of different things. And there's a lot of crossover with general surgery to other, fields as well. And then for vascular surgery, we do not do anything related to the heart. And in our practice, we avoid the thoracic area as well, like the lung, there's a lot of crossover still. Uh-huh. So when it comes to anything from the belly button down, the arms, the neck, like the carotid arteries, things like that. We do a lot of things like opening up blood flow, doing bypasses, things like that. So.
Do you guys what's that test? The CAC, calcium artery, something or other? It's the check for plaques in the arteries. Do you guys do that assessment?
Not in our not in our practice. A lot of what we do duplexes. We look at flow with velocities, and we look for narrow spots. That's our big assessment. If we want to go get a further detail before going in operative, into like an angiogram or something, we'll do like CTAs with runoff, like dye studies that show the blood flow and everything. So.
Gotcha.
Yep.
Yeah.
So, a lot of our patients are sorry, you were saying calcium index. Is that where you're?
I think it's called a CAC test. So if someone wants to check like their risk for stroke or heart attack because of plaques in the arteries, like how do they go about that assessment?
Yeah, at least in our practice, we aren't doing that particularly. With us, when it comes to plaque, one of the things that people get confused about is a lot of our patients, we want them on cholesterol medicine, and it's not because they have high cholesterol per se. They might have a cholesterol test that's totally normal. But what medications that are grouped in the statin class, they actually stabilize plaque. So when people have, buildup of plaque inside their arteries causing narrowing, what can happen is that plaque can rupture, and then you can end up having an occlusion, a blockage. And if an occlusion happens acutely, meaning, suddenly, you can be in a bad situation where you can lose, your limbs or have a stroke or, have those kind of bad things happen. So a lot of my patients get confused. They're like, oh, wait, my cholesterol's fine. I don't need that. And it's like, well, this is more for stabilizing your plaque. And we do that in addition to other, like antiplatelet medicines, blood thinner type medicines.
So statins are not meant to reduce plaques, but like literally keep them in place.
Keep them from moving.
Yeah.
Yes.
Gotcha.
And now if people have cholesterol issues too, you can have that other effect with it as well. But
gotcha.
For vascular surgery, as well as like cardiology, they use statins as well. Same kind of thing. They're just working on the heart instead of the peripheral vessels. Mm-hmm.
Gotcha. What are some emergency symptoms that, besides, obviously like heart attack, what are some things that kind of lurk around that you should not ignore? Like I'm thinking appendectomy or, appendicitis. I mean, like, what are some things that like bring people in your doors that you're like, it's a good thing you got here. This is an emergency.
I mean, being super general, any like acute type of pain that is severe and not going away. But I mean, you could go really far with what you're describing. I mean, like when it comes to the vessels, like arteries and stuff, somebody that has like an acute blockage, a lot of times they get numbness, they get discoloration, they have pain. Some of our patients though already have no little nerve, function in their feet. So sometimes they can't rely on their feeling, but they can look at their legs and see if something looks different in color. If you poke at your foot and it doesn't change at all, and it just stays the same, like a white appearance or whatever, that could be a problem brewing. Abdomen, severe pain, severe back pain. If you're feeling like you're passing out, there's just so many different things.
Right,
and of course, all the stroke symptoms,
Actually, what I had in mind too was when you were talking was we talked about this the other day, the aneurysm, abdominal aortic aneurysm, AAA it's called, because that one, this is like a giant, probably is it the biggest artery in your body?
Yeah, biggest artery in the body. Yep. Comes from the heart.
Yeah, and it can mimic. It'll come up as like back pain. I've actually seen this in the clinic. I saw a guy with back pain, and I know I'm poking and prodding, nothing can reproduce his pain. And then I remember him telling me I could feel my pulse in my belly button.
Yes.
And that was like red flag.
So, I mean, the thing is though, that's normally for thinner patients. Larger patients, sometimes you don't really feel, it's hard to feel it. When I have my little thin patients with an aneurysm, I see their stomach sitting on my table and it's just bouncing. You can see it very, obvious.
Wow.
Now, the big thing I'd say when it comes to aneurysms is if you have a family history of it, you definitely need to be screened for it. And when I say screened, I mean literally your abdomen, your behind the knees can have aneurysms, your brain can have aneurysms. If there's family history, you definitely should be having your primary doctor be looking for it because it's very possible. Most of my patients with aneurysms, they tell me my father died at this age with an aneurysm, and they have a pretty extensive history. Now, not everyone is family history. Aneurysms can come about most of our patients, or a lot of them, smoking is a big cause of aneurysms. High blood pressure is a danger with aneurysms. If you have really high blood pressure, you worry about those areas rupturing. That's the big part of that. So
yeah, actually, we describe what an aneurysm is. I'm not sure if the audience would definitely know what that is.
Yeah. So an aneurysm, you have, first off, super basic with this, heart pumps, it goes through these vessels called arteries. It goes to the brain, it goes to the fingertips, goes to the toes. And those arteries, the biggest one, like we talked about, the aortic aneurysm is one that goes down the heart, and then it goes down the belly region, and then heads down to the feet. So anyway, when you have normal arteries, they are kind of just a normal path, and they taper off at different areas as they branch. But when you have an aneurysm, there's an area that the walls of the arteries are ballooned out. And, when it balloons out, they thin out. And if it keeps getting larger, it can rupture. So that's the big concern with an aneurysm. So.
Yeah, think of it like a hose that's got like a weak spot, and then eventually it starts pushing out, and then just with the wrong diet and lifestyle changes, or maybe just a time bomb, I don't know, it can burst. Yeah,
it definitely. Yes.
What type of like preventative measures? You mentioned testing. What type of tests they do for that?
So, first off, preventative measures would be keep your blood pressure under control, family history, be screened for it, and stop smoking. Definitely. When it comes to screening, normally you can get screened with a simple ultrasound. For the abdominal one, just an abdominal ultrasound can screen for that. We don't do brain aneurysms. I don't know if it's CAT scans the standard or what, so I won't really comment on that. But if there's a history, it's something to be on the back of your mind as well, is there's brain aneurysms. Popliteal also we can screen with ultrasound. So, and a lot of times those popliteal, physical exam, you can feel those a lot of popliteal pulses are not the easiest to feel. The pulse behind the knee cap, if you feel yours very easily, that's concerning. Just like you're talking about with the abdomen. If you see your belly bumping up and down, and that's one thing. Same thing with behind the knee. If you feel a really easy pulse behind the knee, that's something to be worried about, to maybe get looked at. So
yeah. So she's mentioned the word popliteal. That literally means the space behind your knee.
Yep. Yeah.
Now, I do see a lot of Baker's cysts in my clinic, which is like a cyst behind the knee too, in this same exact space, the popliteal space. Is there a way in your mind to differentiate between just like a cyst and besides like imaging? Like if I was just like to look at somebody, oh, this is probably a cyst, or maybe you were dealing with an aneurysm.
Well, cyst would be firm and hard, and it's not going to be pumping. So like an artery is an aneurysm, you're going to feel a pulse, but a very strong pulse. Gotcha. So if you're feeling something firm that's, mobile or not, that's not moving, then that's more likely a cyst.
Okay. So. Gotcha.
Or some other soft tissue mass. Yeah.
And I didn't realize until I was talking to you the other day that there's surgeons that do arteries and surgeons that do veins. Is that right?
Yeah. Technically vascular surgeons are capable of doing either. But it's just one of those things. It comes down to what they want to do. So in my practice, there's 3 of my surgeons like to do vein work. The other 3 of the vascular surgeons prefer not. And we have other referrals that if it's something that we don't typically do or is not something we want to take on, we have other surgeons to refer to. There's some vascular surgeons in the area that only want to do veins. So they don't even touch arteries. So.
Yeah. And you brought up an interesting point the other day too, about how you could potentially fix an arterial problem, but if the venous system's not working, then you create a different kind of problem.
Exactly. Because everything connects. So, with our bodies, it's a whole plumbing system. So your heart pumps the oxygenated blood to the toes and the fingers and the brain, and your veins are supposed to take it all back to your lungs to get more oxygen. So if your veins aren't working well, that's when you have that swelling in your legs. And we do have patients that have arterial and venous issues. And there's times where their venous issues are so bad that we will not fix their arterial issues till we figure out their venous issues, because otherwise they're going to have worsening swelling. Some people have tissue destruction, they get ulcers and things like that with bad vein issues. Just a super easy thing for vein, whatever. If you're traveling, if you're on your feet all the time, it's a good idea to even get some light compression socks to the knees. It's hard in Florida because it's pretty hot here, but it is a good idea to take some work off of your veins. And then another thing too is if you're overweight, it's a good idea to lose some weight, because that also can be a big strain on your venous system. So,
yeah, because the veins, especially in the legs, they fight up against gravity. And what I do know is that the veins can get distended over time, especially with if you're sedentary or not. And then it just pumps and doesn't go up. It pumps and falls down.
The valve can get weak, and then the valves are what keeps your blood going in the right direction. Your arteries pump and your muscles pump, and if the valves are keeping it from falling backwards again. So if everything gets distended, the valves get stretched out. You got leaky valves. The system doesn't work. So there's a lot of things to do about those, but.
Is that okay? Is that the connection between the vascular system and lymphatic system? Like at that point where the blood's pooling, is it now leaking into the lymph? Is that what happens?
That's a good question. I know the lymph system is the third system in the body that can cause. Now, if you don't have venous issues, you don't have arterial issues, you can have a lymph problem, and that's honestly, I don't handle those enough to comment. Yeah. We do see a lot of lymph patients, but we do have referrals sent out a lot of the times for them as well. Yep. There's good pumps to help take that lymph fluid out and help for lymphedema patients, whether it be from, in their legs over time, or if they had, breast surgeries and things like that. But I honestly it's not something I work with a lot.
Yeah.
So.
Yeah, I just know that like if you got a lot of lymphatic swelling, especially in the legs, like if you at the end of the day you take your socks off and their socks have like a big indent on your ankle, and it takes a long time for the to rebound. That's what's called pitting edema, and that's something that you should probably get checked out. To some degree, it's normal. Like if you're just on your feet all day, there's some of that.
Yeah.
But if it takes a long time to rebound, that could be a sign of a vascular issue, particularly congestive heart failure.
Yep. No, there could be a lot. It could be your heart, it could be your veins, it could be your lymph fluid. There's a lot of reasons to have pitting edema, but yeah, something to be aware of, especially if if you have acute onset of like weight gain that wasn't normal, or you're short of breath, that might be your heart that's having some issues. So, but all good things to get checked out.
Okay, good. This is all great info. Let's change topics for a second. What are you into these days, Jeliena? Are you still powerlifting?
Well, now I'm getting back to it. So I had a baby. It's almost coming on 2 years ago, and it was a little difficult to keep up. I was still competing, I think, up until, was it 3 years ago? And then, so I've been back in the gym now the past couple months. So, Mike's been talking about wanting to do another competition soon. So we'll see.
Oh, wow.
Maybe we'll do something together.
And I want to give you the opportunity to brag here because you hold some records still. Do you not?
Probably. I haven't looked. I did for a while in Florida. Yeah. And in which records is, it's
just throw out your PRs. Give it to me. What's your deadlift?
Are we talking geared or are we talking raw?
Let's do both. What's raw and geared?
So let's see. Deadlift. Oh, you're making me think of numbers. So raw was 281 because it was like kilos. So it's a little off the normal. And then geared was like 320. And geared is just like it's extra equipment and it's a different style of lifting. And then bench was 150 raw and then 205 geared. And then squat was it 240 raw, and then geared was also 320. So
that's awesome. You hear that, people? and if you see Jeliena, she doesn't look like that. She doesn't look like a Icelandic powerlifter with like huge upper traps.
You know what? Funny story, real quick.
Yeah.
That I think helped me get into PA school, just having something weird, because I feel like my whole interview in PA school was talking about powerlifting, and I'm sitting here like, do you want to talk about like my academics or anything else that the professors were so intrigued. So it was a cool thing to have something different, So
it's awesome. It's so funny because I bring this up a lot in the whole physical therapy realm. I get a lot of people obviously for back pain. That's like the number one thing we treat as therapists, and they're like, my back hurts. My doctor said, don't deadlift anything. And I'm like, wrong. That's the best thing you need to do for your back. Once you're out of some
proper form,
acute, once you have acute pain, yes, you want to get to deadlifting eventually. But one of the things though, I learned in powerlifting that I didn't learn in PT school is that the size of the muscle does not equal the strength of the muscle. It can correlate, but not necessarily. Like you're a good example. You're not like this jacked, like I said, Icelandic powerlifter, but you can lift some serious weight. I mean,
perfect example is when you see the typical bodybuilder. It's like they have very large muscles, but take them to the gym and
Oh yeah, actually, I have a story about that. I don't know if you even know this story. So this is hilarious. One day I was lifting with Mike at like Anytime Fitness. Do you know the story? Do you know about this?
I don't know. All
right. And we were just deadlifting that day. And Mike, for the listeners, he's a big guy. He was 6'3", 260.
He's like 6, not even 6'1", but he's like 6.5. Yeah.
But he's a guy. But
he'll weigh between 250 and 260. Yes.
Yeah.
And he's muscular. Yes.
Yes. So we're in the gym, and and he's got some big numbers too for powerlifting. But there's this other guy in the gym who's like your prototype, like cheese ball. He's like huge. Clearly, he's done some steroids. Super muscle bound. He's got the tights underneath the shorts. He's got the man bun, and the long beard, and the tats, the sleeve tats, and stuff like that. Sorry, hopefully I'm not offending anybody, but there's a type. And he's benching. I think he's benching 315, which is 3 plates on both sides. And he's making sure everybody knows about it. Right? He's grunting and screaming. And he's like doing like 1 or 2 reps, right? And I know Mike. Mike warms up with 315.
Yeah, I was gonna say.
So Mike's looking at this guy, just kind of laughing, and he's like, "Watch this!" And he goes over there. Now, if you guys don't know Mike, but he's how would you describe it? Just a straight shooter, or
Mike is Mike. What are we describing here?
Yeah,
I don't know.
Okay,
There's
so
a lot
anyways,
you could say.
So Mike goes up with this guy to kind of mess with him and says, "Hey man, I've been wanting to try 315. Do you mind if I hop in there for one?" And the guy's like, "Oh man!" And this guy's like way bigger than Mike. This guy is like probably twice Mike's size. And he's like, "Oh man, I don't know, 315. That's a big number." And he's like, "Well, okay, I think I can do it." So Mike gets on the bench. The guy is like ready to catch the bar. Like he's just afraid Mike's going to drop the bar on his neck. So Mike's, sets up the bench, and then he lifts it off the rack, and he pumps out 15 like it's nothing. Cold. We were just deadlifting. It wasn't even warm. Pumps out 315, 15 reps, and racks. He's like, "Thanks, guy." The guy was his mouth dropped. It was hilarious.
I could see him doing that. Is calling Mike a troll? Is that like, I guess I shouldn't say that.
He's like a big troll.
But that's something he would do for sure.
Awesome. Well, okay, let's wrap this one up. So Jeliena, if people want to find out more about you, where to find you and have your services, where do they go?
Well, I mean, they can go to our website, Surgical Specialists of Southwest Florida. We're all listed on there, and we have offices in Fort Myers and Cape Coral, and we're here to serve.
Okay. Well, awesome, Jeliena. Thank you so much for coming on.
All right. Nice seeing you, Chris.
You too. All right, Florida. I'll talk to you next week. Do you have unexplained pain, or do you wonder just how healthy you are? When was the last time you had your blood tested? Blood chemistry analysis is a great way to stay ahead of any health conditions, and now you can have control of your health with Let's Get Checked. Let's Get Checked is an incredible company that sends blood tests to your home. You can choose from over 30 different tests, whether that's liver function, testosterone, micronutrient, cholesterol, or C-reactive protein, which is a marker for inflammation. It's sent to you with free shipping, and you get your results in 2 to 5 days, no physician referral needed. Use the code DPT30 for 30% off. Go to letsgetchecked.com and use the code DPT30. Did you know that you can get started with physical therapy without a physician's referral? Physical therapists don't just solve pain, we get down to the root cause and keep it from coming back. We also discuss all things health, such as nutrition and lifestyle changes. If you feel that you could use some help, let's get on a free consult call. Go to www.dynamicnaples.com and sign up for a free call. Also, if you like this podcast, please give us a rating wherever you listen to podcasts. It helps us spread the message. Thanks for listening, and we'll see you next week.